Coming to question 9, a 55-year-old male with acute kidney injury was initiated on CRRT while in the intensive care unit with the following prescription. The prescription is given below. You are called by the ICU staff nurse because of 3 clotting episodes within the last 24 hours. Our CBC showed a HB of 12.1 and a hematocrit of 40%, which the following is the next best step in the management of this patient. First of all, the patient is receiving pre-filter replacement fluid. So first you need to understand the difference between the pre-filter replacement fluid with that of the post-filter replacement fluid administration. As we have discussed already in the video lectures, pre-filter replacement fluid will be associated with lesser clogging and lesser clotting, and it's going to increase the life of the filter. But one potential problem that you will encounter here is reduced clearance as well. The overall clearance rates will reduce because you are diluting even before the blood is entering the filter. On the other hand, giving fluid replacement post-filter is going to increase the clearance. It's a kind of an advantage. The solid clearance will be high because of kind of hemoconcentration that is developing at this level of the filter. But because of the same hemoconcentration in post-filter fluid replacement, your clotting and clogging incidences will be a bit high, and that's going to definitely reduce the overall life of the filter. And these are some disadvantages with post-filter fluid replacement. In general, we are going to utilize the advantages of both pre and post-filter fluid replacement so that we use a combination in real practice. So that some of the replacement fluid will be given pre-filter and some of the replacement fluid will be given post-filter in general. So what about our patient? Our patient is receiving only pre-filter replacement fluid. Then why this patient should develop 3 clotting episodes in the last 24 hours? Remember, if you are using only pre-filter replacement fluid, then the clotting incidence should be low only. But despite that, the patient is getting increased clotting episodes, means your anticoagulation is ineffective and insufficient. That's why the right answer for this question will be to add regional citrate anticoagulation. In case if the patient is receiving both pre-filter and post-filter fluid replacement, or if the patient is receiving only post-filter fluid replacement, then it's imperative that you calculate something called as filtration fraction. So what is filtration fraction? It's the total ultrafiltrate rate, which is nothing but pre-filter fluid replacement rate plus post-filter fluid replacement rate plus your net fluid removal rate, which is sometimes given as ultrafiltrate in certain prescriptions. It should be divided by the blood flow multiplied by 1 minus hematocrit, the blood flow through the filter multiplied by 1 minus hematocrit plus your pre-filter fluid replacement. So in our patient, the total ultrafiltrate rate will be 3600 because patient is not getting any replacement fluid post-filter and the patient's net fluid removal rate is 0 here. So I can write the total ultrafiltrate rate is 3600, but remember the units that's given is ml per hour. And what is the blood flow? The blood flow is 150 mLs per minute. So it should be calculated in hours as well because the SI unit should be the same in the numerator as well as the denominator. So I can say 150 multiplied by 60 mLs per hour multiplied by 1 minus hematocrit. 1 minus, here the hematocrit I think is somewhere around 40% in this guy. Yes, it's 40%. So 1 minus 0.4, that is 40%. Plus your pre-filter replacement, that is 3600. So the formula will be coming up to this 3600 divided by, I think you will get somewhere around 5400 plus 3600. So it will be 3600 divided by, I think, around 9000. So you will get a value of 40%. That's what you're going to get. So remember, a filtration fraction of more than 25% is going to tell you that there is a high risk of clotting and clogging. So you need to reduce the filtration fraction to less than 20%, ideally. 15% is the best value. So here the patient is having 40% in our example. But I can ignore that 40% because it's just a mathematical calculation. Because the patient is getting only pre-filter fluid replacement, even though this patient is having a filtration fraction of approximately 40%, I can ignore it because pre-filter fluid replacement only means it's not going to be associated with significantly increased risk of clotting. That is the reason why other options are going to be definitely wrong. And switching to post-filter CVVH is going to increase the episodes of clotting even further, because we already know that post-filter fluid replacement alone is going to have high rates of clotting and clogging, and that's going to reduce the life of the filter dramatically. And this patient is getting a proper dose of CRRT at around 25 ml per kilogram per hour, and as such, increasing or decreasing the effluent rate is not going to work with regards to the CRRT dynamics. So it's going to reduce or not going to change the efficiency of CRRT acid. So that's why the right answer for this question is going to be adding your regional citrate anticoagulation, which will be the best choice.
Subscribe and press the bell icon so you never miss an update from PrepLadder.